Bismillahirrahmanirrahim. Welcome to ERA. I am Dr. Muhammad Talan, Assistant Professor of Radiology, Cairo University. Today we will continue our emergency CT brain course. This is CT brain and contrast CT scan of the brain for a trauma patient. We don't have any extradural hematoma, no subdural hematoma, no brain contusions. We should go with our checklist from outside to inside. So we have here something abnormal in the left high parietal region. As you see here, this is a normal subarachnoid space, dark inline CSF density. This is a normal CSF density, but we have here branching blood density. So we have here smearing of the cortical site. It's a good description for the subarachnoid hemorrhage. This is localized subarachnoid hemorrhage at the left high parietal region. The good description is smearing. Smearing of the cortical site by blood density. This localized subarachnoid hemorrhage is located at the left high parietal region. So it is peripherally located, peripheral subarachnoid hemorrhage. The most common cause for the peripheral subarachnoid hemorrhage is traumatic. The another less common cause is cerebral amyloid angiopathy. We will describe this entity in a separate opinion. So the gold standard here, or the message that I want you to know, that the peripheral subarachnoid hemorrhage most likely of traumatic cause. On the other hand, if we have any subarachnoid hemorrhage in the basal cistern, for example here, or along the sylvian fissures, we should think for rupture aneurysm or rupture AVM. So it is different way of thinking. We have modified fissure grading. We can grade the subarachnoid hemorrhage by modified fissure grading. We have different grades. Grade 1, it is thin subarachnoid hemorrhage. As you see here, this is grade 1. Grade 2, if we have thin subarachnoid hemorrhage plus intraventricular hemorrhage. So if we add intraventricular hemorrhage, it will be grade 2. Grade 3, grade 3, if we have thick subarachnoid hemorrhage. Grade 4, if we have thick subarachnoid hemorrhage plus intraventricular hemorrhage. How can we differentiate between thin and thick? We don't have a gold standard, or we don't have a figure or a specific thickness, but it is subjective. So we have here post-traumatic subarachnoid hemorrhage at the left high parietal region, and also we have here left high parietal extracranial subgaleal hematoma, and confirm the site of the trauma. As we discussed in the previous vignettes, once we have any trauma, we should search for coup and counter-coup injury. We have here, this is the coup. Search for any counter-coup. Counter-coup can be present at the opposite direction, maybe here. So you should search at the right frontal region, sometimes at the right temporal region. We don't have any injury along the counter-coup side. The differential diagnosis for the subarachnoid hemorrhage is very important because we have a term called pseudo subarachnoid hemorrhage. Pseudo subarachnoid hemorrhage can be secondary to venous thrombosis. If we have cortical vein thrombosis, sometimes it looks like subarachnoid hemorrhage, sometimes meningitis, as TB meningitis. And third, if we have severe hypoxic ischemic insult for the brain, this will cause severe cerebral edema. And once we have cerebral edema, it will reduce the brain tissue density. So the meninges beside the brain can be slightly hyperdense in relation or relative to the brain tissue, but it is not subarachnoid hemorrhage. We will try to get some cases with pseudo subarachnoid hemorrhage. Second case today, this trauma for a child. We don't have any subdural or extradural collections. We don't have any brain contusions. But we have here subgaleal hematoma. So this is the site of the trauma. And if we concentrate more at the right parieto-occipital region, look for this area. We'll find smearing of the cortical sulci by this blood density. Sometimes it's difficult to pick up, but you should search for any subarachnoid hemorrhage. This is an example for subarachnoid hemorrhage, localized subarachnoid hemorrhage at the right parieto-occipital region. Most likely, as we said before, the peripheral subarachnoid hemorrhage, most likely post-traumatic sequelae. And according to modified Fisher grading, it is classified as grade 1 because it is thin subarachnoid hemorrhage with no intraventricular hemorrhage. To save your time, I checked the bone and there is no bone fractures. This is a third case today. This is a young adult patient presented by sudden drowsiness, sudden feeling of drowsiness and confusion. The most gross abnormality here, this is this hematoma. This is an irregular shaped intracerebral hematoma located at the right temporal region. And this hematoma is surrounded by hypodense brain edema. So there is no history of trauma for this patient. We will describe in another vignette the different types and different causes for intracerebral hematoma. But the second thing, or the second abnormal thing in this image, if you see here, this is the Sylvian fissure. This is a normal Sylvian fissure, CSF density. But if we see the contralateral side, this one, you will find it's difficult to see the Sylvian fissure because it is obscured or totally obliterated by high density material, as you see here. So may we think together that this one may be subarachnoid hemorrhage. So how can we make a link between the intracerebral hematoma and the subarachnoid hemorrhage? There is no history of trauma. So how can we think again? Do we have possibility of cerebral amyloid angiopathy that can induce intracerebral hematoma, peripheral intracerebral hematoma, and subarachnoid hemorrhage? It's very difficult because this is a young patient and the subarachnoid hemorrhage is away from this intracerebral hematoma. So it's very difficult to have this one. So let us go with our checklist. Once we have any challenging case like this, go by your checklist. You may find an extra finding that may explain the abnormality. So if we go with our checklist, as we said in one of our videos, we should check the vessels. This is a non-contrast CT scan of the brain. Look for the internal carotid arteries not enhancing. The cerebral arteries not enhancing. So we are dealing with non-contrast CT scan of the brain. Venous sinus, as you see here. This is the straight sinus, and this is the superior sagittal sinus. Both of them show hyperdense sign, suggestive of acute dural venous sinus nodes. If you see this one, this also is a straight sinus. And if we need to make it like this, you will see also the hyperdense superior sagittal sinus. Even the internal cerebral veins also hyperdense. So we have a case of acute dural venous sinus thrombosis. So let us think again. The story is totally different. Initially, when I started to report this case, I thought that this one may be true subarachnoid hemorrhage, but after detecting acute dural venous sinus thrombosis, this one most likely pseudo subarachnoid hemorrhage because of thrombosed cortical veins and engorged cortical veins. Also, we can explain this intracerebral hematoma and this brain edema, cerebral venous infarction secondary to cortical vein thrombosis. This is the most logic thinking in this case: acute dural venous sinus thrombosis, cortical vein thrombosis and engorgement, and secondary intracerebral hematoma and or cerebral venous infarction. Thank you for listening to our lectures.